Good morning, everybody. Welcome to our Population Health and Epidemiology session. My name is Sonia Stanojevic. I'm based at the University of Dalhousie in Halifax, Canada. I'm a respiratory epidemiologist. I love data, and I'm really pleased to welcome you today to our session. This is my co-chair, Dr. Grant.
Hi, my name is Grant Turner. I'm a CF and lung transplant pulmonologist at the UCLA.
Great. So we have an exciting lineup for you this morning. Lots of cutting edge methods and very interesting results. I just want to remind everybody, you can post your questions in the app. So if you go to our session, there's a Q&A, it'll come up here. We also have the old fashioned mic for those of you that want to stand up and ask questions. So in either case, we have lots of opportunity for discussion. Unfortunately, one of our speakers was not able to come today. So we have a little bit more flexibility with timing and lots of opportunity for discussion. So I encourage you to come and make your comments and questions at the end of each session. So without further ado, we're going to get started. I'd like to introduce our first speaker, Dr. Hinton, who's going to talk to us about timing of clinic visits. Welcome.
Good morning, everybody. Not a doctor yet. I'm in a PhD program, so hopefully soon. But thank you for inviting me to participate in this session, and thank you all for being here today. I was told there's a delay in slides, but that feels a little too long. Okay. So I have no relationships to disclose. And I apologize for my voice. I'm recovering from a little viral thing, and the voice is like the last thing to come back, of course, when I'm presenting this happens. But so bear with me. Hopefully I keep my voice through this. So today I'm going to be presenting on some work that tries to understand which characteristics predict how long people with CF go between clinic visits. And how this plays out across the lifespan. I'm going to start by giving you some background on why this is an important question, and then I'm going to touch on some prior findings. If any of you were at the Models of Care talk yesterday, Dr. Brown gave a really fantastic talk. I encourage you to go watch it once I post it. But she gave some background on the care model as it exists now and how people are thinking about changing it to better meet the needs of patients. So the current recommendation is that patients go in every 3 months, so 4 times a year, to a specialized CF clinic. The guidelines were established in the 90s, and we all know there have been enormous strides in advancing CF care since then. As we heard at the plenary yesterday, the median age expectancy is now 56 years old, and back in the 90s, or in the 80s, it was more in the teens. So it's been a huge change. And so we used the national registry data to try and understand who's been missing visits, what predicts why people are missing visits. And we know that they occur frequently. So prior work has shown that about a third, more than a third, are missing a full year of visits at some point during their lifespan. So our prior work examined if missing visits harms lung function. And we hypothesized that it would, and that the effect would vary by age and by genotype, which can be an indicator of disease severity. These figures here show These figures show, they show FEV on the y-axis and age encounter on the x-axis. And then the 2 lines here, the black line represents people who had less than a 12-month gap in care preceding their visit. And then the dashed line shows people who had 12 months or more gap in care preceding their visit. So you can look at this figure, and if you look at age 18, and go up, you can see that the difference between the two lines is about a 1% difference. And so if an 18-year-old comes into the clinic and had missed the prior year of visits, you would expect their lung function to be 1% lower than the same person if they had come in for all of their visits preceding that visit. So that might not seem like a huge change, a 1% difference. However, that's what we expect a person to lose in over the course of a year. So it is actually, a clinically meaningful difference between people who miss visits and people who don't miss visits. So we know that people are missing visits, and we know that it hurts lung function. So these findings prompted us to ask, so who is it that's missing visits? We suspected that healthier people would potentially choose to come in less frequently, but we also suspected that we'd see evidence of barriers to care that might cause people to also not come in for visits as recommended. As I said, to answer this question, we used data from the National Patient Registry. We used data from 2004 to 2016, and this included people between the ages of 6 and 45. And so our analysis included over 24,000 people and 700,000 visits. And our outcome of interest was the time between visits, so that's the days between each clinical encounter. I want to note that we didn't differentiate between hospital visits and clinic visits. However, we excluded any visits that were less than 30 days since the prior visit so that we can focus more on these routine encounters. We log transformed this outcome to meet normality assumptions. This slide shows a list of our exposures of interest. This includes some sociodemographic factors and disease characteristics. These are what's available in the CF registry, and we know that this just barely scratches the surface of the reasons people may or may not come into clinic. And as we heard yesterday during the Models of Care talk, patient decisions are incredibly complex, and they include many things that are not tracked in the registry. But this is a starting point. So to model this relationship, between these characteristics I just mentioned and the time between visits, we used longitudinal semi-parametric modeling with subject-specific random effects. So the longitudinal piece means that we included all of the visits for each patient over up to a 14-year span. The semi-parametric piece is the splines, which we included splines for age, which means that we expect the relationship between missed visits to change over time. We don't expect that every single person is missing visits with a regular pattern over their lifespan. This is the model here. So our outcome is time between visits at the bottom. Here you can see the model. And then these are all the factors that we included in our model. And some of these we expect not to change over the life course. So like gender we assumed would not change, race and genotype. However, certain other things we expect to change over time, and we allowed the model allows for that to happen. So insurance status might change, infections might change over the lifetime. Okay, so here's our results. So I'm going to orient you a little bit to this figure first. On the y-axis, we have length of time between visits in days. And then on the x-axis, we have age at encounter. And the dashed line at 90 represents how often people are recommended to come in. So every 3 months is approximately 90 days. And then these lines are, on this figure, represent males in blue and females in pink. And if you just focus on the younger age group, you can see that children generally are attending clinic within the recommended guidelines and, a little bit more frequently than recommended. Around age 15, the gap between visits begins to increase. And then around age 20, for males, it actually crosses that threshold, and they're going longer than recommended after age 20. So this is all on average, of course. So here's a similar figure breaking it down by genotype. For simplicity, we categorize genotype as those having 1 or 2 copies of the F508del mutation, and then everybody else is grouped into the other or unknown category. And you can see here that those with 1 copy of the 508 deletion are who generally have milder phenotypes, are going longer between their clinic visits. So this is a similar graph breaking it out by insurance status. And sorry, this is like such a dense graph. There's a lot of lines here. I tried to label them so that it's a little bit easier to understand. But those with no insurance, as you might expect, are having the longest gaps between visits. And those with private insurance are actually coming in pretty frequently. And the people with private insurance are somewhere in the middle. So this is kind of a combination of race and insurance, because I was wondering if the effect of insurance might differ by race. And so the solid lines here are not people who are non-white, and the dashed lines are people who are white. And due to the low number of non-white people, we couldn't split it out more than that, unfortunately. But you can see from this that the lines pretty much, for the most part, are pretty similar by insurance type, split out by race, which is a little surprising to me. We also, kind of surprisingly, did not see evidence that the time between visits differed by the patient's rurality. So these lines kind of looks like a bunch of spaghetti noodles all on top of each other. So there's not a whole lot of difference by people who are living in rural areas versus urban areas. So as we hypothesized, sicker people generally do come in more often. And you can see on this figure that this is a slightly different figure. So on the x-axis, it shows the adjusted percent difference from the reference group. So if you look at diabetes, for example, you can see that compared to people without cystic fibrosis related diabetes, the people with diabetes are coming in 10% more frequently than people without diabetes. So the fact that all these are to the left of 0 means that those people are coming in more frequently. And here's a figure that is more like the ones I've been showing you. So here, this is a slightly different model. We grouped all of these factors on this slide into one variable that says, did they have a complication or not? And you can see that the people with complications are in the blue line are coming in more frequently than the people with no complications in the pink. So our prior study shows a small but important impact of gaps on lung function, and that gaps in care are common and vary across the lifespan. We hypothesized, and the data confirmed, that sicker patients come into clinic more often and that healthier people attend less often. But we also found that other factors such as age, gender, genotype, and insurance status are also importantly associated with visit frequency. As patients and providers consider modifying the model of care in CF, it'll be important to better understand the sociodemographic and structural factors that shape how patients interact with the healthcare system. So I want to thank some of my collaborators and mentors listed on this slide. And that's it. Thank you.
That was a wonderful presentation. Thank you so much. I'll open it up for questions. Greg, walk faster while we get the iPad going. All right.
Good morning. Greg Sawicki from Boston Children's. This is fantastic work, and I really love the way that you visualized the longitudinal trends over someone's lifespan, or at least what we're seeing by age, because I think what's very clear from this data is that pediatric programs are so different than adult programs just at baseline. I think we've known that for a long time, but it's really striking to me that there's such consistency in the younger ages in terms of being under that 90-day, 3-month average, and then it all goes apart during the transition age. And we've done work, and others have done work looking at gaps in care during transition and adverse outcomes. But it seems like this is a real sort of important message to send, I don't know what's the right answer, but, are adult programs doing things correctly? Are they doing things, and a lot of this is pre-ETI as well. Is it that we should be working with adult programs to change their model to be more frequent, less frequent, individualized? I think but the way you visualize the data is really, really, really impressive. But I'm wondering if you can comment specifically about that difference sort of in that transition age. Did you see anything in that 18 to 25-year-old time where people often are moving or moving centers, that it didn't seem to be as much of a signal in the work, but I don't know if you looked more specifically at that and some other risk factors.
Yeah, we plan to look at that more in like a slightly different analysis that'll help us kind of answer that question a little bit more specifically. But it does look like from this work that the gaps kind of start there. Like maybe the gap while they're transitioning is important, but the gaps after that, they continue. So it's not maybe necessarily that gap, but exactly when they're transitioning. That's probably important too, but it's a really important question.
Thanks.
Thanks. And we do have a question from the audience online, so I'm just going to read it out. What was the rationale for combining hospitalizations with clinic visits for the outcome? Did you do any analysis only looking at clinic visits?
Great question. That is a limitation of the data that we have in hand. I wish that we had requested the variable that tells you whether it was a hospital visit or a clinic visit, but we just didn't have it. So definitely something to consider, if we get new data. We requested new data and we plan to redo this analysis using data from, 2017 on, so that'll include when people are on modulators and telehealth, and we've requested that variable, so we hope to include that next time.
I might just have one more question. So in adults, as they become more independent, as they become more engaged and able to work and have families, that balance of coming in for quarterly clinic visits is quite challenging. And so I know you're working on this, so I'm going to ask for the audience. Not coming to clinic visit is associated with poor lung function, but you very clearly show that there's some self-selection in healthy individuals not coming. And how might you look at kind of the optimal timing of a clinic visit for an individual? And is that something that you're planning to do?
Yeah, thank you. It's definitely a complicated question to answer. We did see a 1% decrease overall if you miss a year's worth of visits. Sorry. But in that analysis, I didn't present it, but we also did a sensitivity analysis looking at 6 months and 18 months, and there's a dose response there. So 6 months going 6 months between your visits is less harmful than going 18 months between your visits, as you might expect. So there's a bit of a trade-off there, for people who are living, healthier, longer lives where they have families and jobs and stuff. The trade-off might for them be okay to potentially lose just a little bit of lung function as a trade-off for not coming in as often. On modulators, we may see a whole different set of results. It may not be quite as harmful to lung function. And we have telehealth, so that could be a good substitute. We don't really know how that impacts lung function at this point. But I am hoping to use some different methodological techniques to look at these kinds of questions, particularly target trial emulation and causal inference methods, where we could really look at the effect of missing not just the visit, like the results I showed you earlier, our other study, we're looking at a gap in care immediately preceding that visit. Like, we don't know what happens over the course of a couple years. And I think that's kind of getting to your question a little bit more, is like, what happens in real life situations, and how do we help patients answer, like, how do we do shared decision making to help people understand what the trade-offs are? So more work to come.
Oh, with one more question. Go ahead. Yeah.
To that, what do you attribute then is being missed by missing a clinic appointment. The person's sick and they're not getting treatment. So just to see if you can flesh that out a little bit more to speculate that. About that.
Yeah, thank you. So, you know, there's this question of, so people are missing visits, but is it the missed visit? Is it being seen in person that really matters? Or is it because they didn't get a spirometry measurement? Or is it because they didn't get a sputum culture? Is it because they have these chronic infections that aren't being treated earlier? Maybe they're being treated later once they already have an exacerbation. So those are kind of on the causal pathway between missing visits and the lung function outcomes. So we are hoping to do a mediation analysis to kind of understand the effects of those pieces of care and which ones are most important to maintaining lung function.
Can I ask one quick question?
Yeah.
As a transplant doctor as well, I wondered if you guys excluded people who had transplants?
We did.
Oh, okay, perfect.
We excluded people starting the year prior to transplant so that when they're coming off meds and prepping for the transplant, they're not included in the data.
Perfect, thank you.
Sorry, just a question.
Yeah.
I'm curious, there was a presentation yesterday that looked at delays in time to ETA uptake for racial and ethnic minorities that I think controlled for missed clinic visits, or I think actually just like excluded everybody who had missed clinic visits. I'm curious if you think that would impact things.
That's interesting.
Like whether you think missed clinic visits are related to some of the barriers to accessing ETA.
Yeah, I'm sure that it does. This analysis here wouldn't answer that question because it's pre-modulator. But it's definitely something to consider in our 2.0 version when we get the newer data. But absolutely, yeah, if you're not coming to clinic, you're not getting modulators. But, we didn't see a huge effect by race, so I don't know. We'll have to see.
Thank you so much for a great presentation.
Thank you.
Next, we'll have Stephen Colgate talk to us about evaluating precision medicine tools in cystic fibrosis for racial and ethnic fairness.
Click start. Okay. Here we go. Here we go. Cool.
Forward, it's the buttons at the bottom.
Okay. Thank you. Okay. All right. Good morning, everybody. Thank you all so much for coming to this talk and this session here today. My name is Stephen Colgate, and I'm going to be sharing you some of the work that I've been doing at Cincinnati Children's Hospital as a postdoctoral research fellow here. There are no relationships to disclose related to this presentation here. So Cincinnati Children's has developed a non-stationary stochastic process model that predicts probabilities for rapid lung function decline. This model is based on cystic fibrosis patient encounters from the CF Foundation Patient Registry to forecast FIAS risk, or FEV1 indicated exacerbation signal. And this database here collects information from cystic fibrosis patient encounters who receive care from these health centers here. The precision medicine algorithm determines the probability that a cystic fibrosis patient, when they come in to get clinically evaluated, whether or not they'll experience a future pulmonary exacerbation event from the date of the encounter here. This precision medicine algorithm has been shown to accurately predict FIAS occurrences 3, 6, and 12 months from clinical evaluation here, and it serves as a useful tool to identify whom and when a pulmonary exacerbation is imminent. And so when I I decided to take a look at this model here and evaluate it based on the grounds of precision medicine, evaluating how well these predictions are based on actual event outcomes. And the goal here is to improve the algorithm's accuracy and precision of determining future pulmonary exacerbation events. We looked at it on the base of group fairness versus individual fairness. Individual fairness primarily focuses on individuals that have similar characteristics being treated in a similar fashion. That requires each individual to be treated the same. And group fairness, where a population is partitioned into groups by protected attributes. So that way that the model itself requires statistical parity across all of those groups. So we expect similar performance in the prediction algorithm among those for various different races and for various different ethnic groups here. But there has been concerns about racial equity in many precision health algorithms that is present in real world health algorithms that explicitly don't use race as a predictor. And so leaving out the race as a predictor does not necessarily address this problem. And most of the precision medicine research work today does not incorporate group fairness into their statistical evaluation process. And they may not even consider a group bias as a design selection here, whereas researchers instead primarily focus on the accuracy and interpretation of the algorithm that's being developed, which is primarily based on the individual fairness approach. So precision medicine algorithms, they commonly use covariates that are associated with race and ethnicity, and that could induce differences in pulmonary exacerbation prediction when it comes to our precision medicine algorithm between racial and ethnic groups. Using predictors that are associated with race or ethnicity doesn't necessarily imply that the predictions will be unfair. While we do expect to see differences in pulmonary exacerbation predictions from this precision medicine algorithm between various different groups, we don't expect to see differences in prediction accuracies between these groups. So for our aims, we characterize the group fairness and performance of our pulmonary exacerbation algorithm based on race and ethnicity by performing a diagnostic analysis by comparing prediction accuracies between these groups. We then took a look at the predictors and outcome variables that are used by this precision medicine algorithm to identify how ethnic and racial differences in prediction accuracies are incorporated. And we identify any predictors that are associated with race or ethnicity here. So what we did was we took data from the Cystic Fibrosis Foundation patient registry, which identifies race as one of these various different categories that are here. We then took these categories and then identify an individual's race as either white if they identified as only white, black if they identified as being black, or as some other race which is identified as any other race is selected besides white or black. We then define an individual's ethnicity based on whether they chose to self-report as either Hispanic or non-Hispanic. The cohort here involves 26,392 individuals, and it's primarily made up of white patients and those in the non-Hispanic group here. Pulmonary exacerbation events, we identified them based on the FIAS definition, which is first determined by identifying the baseline FEV1 value, and then we compared that change in FEV1 percent predicted from the baseline value based on how much it changes relative to the baseline value here. We incorporated a 28-day washout period between consecutive FIAS-defined pulmonary exacerbation events here to make sure that the FEV1 values, percent predicted values, diffuse back to their baseline here. The algorithm uses algorithm harmonized variables to forecast FIAS risk, such as medical history, the patient's residence location, and their FEV1 measurements. And additional place-based variables were also incorporated, such as roadway density, drive time to the healthcare center, community material deprivation, and green space to determine FIAS risk. What we did was we took this algorithm, we found the probability of a pulmonary exacerbation for each patient at every clinical visit from the precision medicine algorithm, and we fit an ROC curve to the entire cohort to calculate the overall optimal cutoff probability here. This probability that maximizes both sensitivity and specificity for the entire cohort here. We fit the ROC curve using the optimal cutoff probability here, and then set up our diagnostic test this way. We calculated the overall sensitivity and specificity in the area underneath the curve for the optimal cutoff probability here. And we repeat this diagnostic analysis for 3 prediction horizons, for 3-month predictions, 6-month predictions, and 1-year predictions here. We then took a look at the overall optimal cutoff probability and applied it to 6 various groups: 3 racial groups, white patients only, black patients only, and other patients only, and ethnic groups, which consists of Hispanic patients, non-Hispanic patients, and those who didn't self-report their ethnicity. We fit an ROC curve to each group separately using that optimal cutoff probability here, and computed the sensitivity, specificity, and AUC for each of those groups. We then repeated the diagnostic analysis for the 3-month, 6-month, and 1-year prediction horizon. And all these calculations that were done here were performed in R using the package PROC. By construction, we're expecting similar performance for each group using the overall optimal cutoff point here. And so we're expecting that if this precision medicine algorithm meets the group fairness here, that we expect the accuracies and model predictions to be similar between the groups here. Any discrepancies and benchmarks between groups will signal bias in precision medicine algorithm performance. And so we'll look at the predictors and the outcome that are used in the precision medicine algorithm to identify why there are differences in performance between groups. So taking a look at some of the predictors here, we analyze each predictor and outcome to determine associations with race and ethnicity based on a various different list of variables here, including gender, smoking status, insurance status, green space percentage, roadway density, distance to the healthcare center, how often they come in for a clinical visit, how many pulmonary exacerbation events that they experience in a year, and the length of time between baseline age at each encounter. With some of the significant results that we saw here, we saw differences in distribution of F508del mutations here. And so differences exist by racial group in that distribution, where whites were predominantly F508 homozygous, while blacks were mainly patients were mainly F508 heterozygous, while those who identified with another race had a balanced distribution of F508del genotype here. We took a look at these variables here, and we found that there were differences in private health insurance here. We noticed that black patients were less likely to have private health insurance. We also noticed that black patients were more likely to experience secondhand smoke exposure, and were also more likely than white patients to be living in a smoking household here. Looking at some of the other predictors that we looked at here, these are the ones that we noticed that were significant between the groups here. We noticed that black patients were less likely to live in neighborhoods that have ample green space in their neighborhoods. They were also more likely to have higher community deprivation index values here. Looking at some of the roadway densities between the racial groups here, we notice that black patients tend to live in neighborhoods with higher roadway density averages, but they were also tend to live on average closer to their healthcare center and have a shorter drive time to their healthcare center from where they live. Here. So black patients tended to live in neighborhoods that feature denser roadways, and they also tended to live closer on average to their healthcare center here. When we took a look at the clinical visit summary, we noticed that the average number of clinical encounters was only significantly borderline significant by racial group, but the average number of clinical encounters was highest for black patients compared to black patients, even though black patients lived closest to their healthcare center compared to white patients. The rate of clinical encounters is different by racial group, though the rate of positive pulmonary encounters and negative pulmonary exacerbation encounters were only borderline different. Taking a look at our ROC curve analysis here, there was differences in the optimal cutoff point for 3-month, 6-month, and 12-month outcome here. And looking at it by race-specific cutoffs here, you can see that there are differences in the optimal cutoff performance if each group was to have their own probability cutoff here for 3-month, 6-month, 12-month prediction horizon. It varies widely by race, and then when you look at it by Hispanic and non-Hispanics, it also varies widely by ethnicity. Taking a look at our ROC curve analysis here for the area underneath the curve, we noticed right away, and this is kind of one of the major findings from our analysis here, we noticed that the area underneath the curve for every prediction horizon here, Black patients tended to perform worse overall than those in the other racial groups here. Interestingly enough, we don't really see that pattern present between Hispanic and non-Hispanic patients here. And when we took a look at it by sensitivity and specificity, we noticed that all across the board, as you look at race here, we noticed that Black patients have lower sensitivity and lower specificity values for every single prediction horizon compared to those of other races here. So if you look at the numbers at it from here, we don't really see that result for the Hispanic and non-Hispanic patients here, which was kind of very interesting to see that here, but we did notice that difference in prediction accuracies for Black patients compared to those of other races. So they had lower sensitivity, specificity, and AUC for every prediction horizon here, and white patients had higher sensitivity, specificity, and AUC for every prediction horizon. Patients who I self-identified with another race tended to have higher AUC for every prediction horizon compared to Black patients. And we thought this was really, really striking and very, very concerning, because even though we didn't find any evidence of ethnic discrimination in prediction performance here, the precision medicine algorithm that was built here at Cincinnati Children's had the worst prediction performance for Black patients when compared to white patients or patients from another race. And we did this by looking at various different sample sizes, different cutoff probabilities, selection methods, or how we evaluated the model evaluation. No matter how we tried to twist the results and tried to remedy this problem here, the racial bias cannot be attributed to any of those factors here. We even did simulations where we pulled those of sample sizes for each racial group and redid the analysis here, and we still saw discrepancies in prediction performance. So that must tell us that systemic racism has to exist either within the algorithm or within the data used to create it, or for both. So discrepancies of various predictors that are correlated with race, they could affect precision medicine algorithm predictions. We noticed that there were differences in F508del mutations, the locations of where these individuals live, they could be a factor here, and awareness. How often do they go and get evaluated for a pulmonary exacerbation here? How is their accessibility? Does every person have the same equal opportunity to go and get evaluated for a pulmonary exacerbation or not? So the next step of our results here, noticing that we got here, is how do we address this group level fairness problem in our precision medicine tools? And how can we remedy this situation so that people of all races could have similar precision prediction accuracies from cystic fibrosis precision medicine algorithms? So we're going to be looking at our precision medicine algorithm to address racial bias by taking a look at individual fairness and group level fairness here. The only thing that we can think of here is that if you try to address group level fairness, you're going to have a trade-off in prediction accuracy by accounting for that group level fairness. But we hope that by this talk here today, we want to bring awareness that whenever you collect data or whenever you fit an algorithm or you fit a model, you may be incorporating some racial bias that may not be present there when you actually evaluate it by group level fairness here. We're going to construct an optimal learning curve procedure to achieve ideal maximization of fairness and accuracy using 3 different approaches. One would be to debias the input data by group, test various different precision medicine algorithms to see if that takes care of the group fairness problem, and then or calibrate the model predictions by group here. And we also want to reach out to clinicians, those who are actually doing pulmonary exacerbation evaluations, to gather their feedback here. What's their goal when they're actually using precision medicine tools? Is it to maximize prediction accuracies, or should group fairness be more emphasized in their medical work? And how important is that accuracy to maintaining that group fairness, the collection of the data that they get, and the deployment of the precision medicine tool? So the feedback that we get from the clinicians will help us to build a protocol to resolve these group level fairness concerns in precision medicine algorithms. Thank you so much for your attention, and I'm looking forward to your questions and feedback. Thank you.
If anyone has any questions, please feel free to come up to the mics, or feel free to put them in the app.
Hi, Michael Schechter, Children's Hospital Richmond. This is impressive in terms of the work that's been done. But there's a couple of things. First of all, so clearly you've got prediction models that aren't working as well for racial and ethnic minorities. And so that, again, from the standpoint of the technician who's developing these sorts of algorithms, that's an important challenge. But from the standpoint of clinicians, let me ask you this. Are you finding that the prediction model is giving you more false negatives or more false positives in the prediction of these exacerbations? I mean, that's actually something that's important for us to get a better handle on. And this is especially true given what I think most people recognize is the arbitrary nature of the diagnosis of pulmonary exacerbations. It's, you know, we're using that as a gold standard, but the gold standard has a lot of tin in it. You know, there's a lot of different ways of looking at that. But again, so the bottom line question that I'd like to know is, are you suggesting that we are that we're finding fewer exacerbations being diagnosed than would be predicted, or more exacerbations diagnosed?
Yeah, thank you for your question. This has been something that we've been talking about within our group, is how do you actually define a pulmonary exacerbation? Because it changes depending on which definition that you use here. So what we've been toying around back and forth here with, how do you actually compare actual pulmonary exacerbation outcome, 3 months, 6 months, or to a year. And what we found was that one of the drawbacks of our data here was you can only be identified for pulmonary exacerbation if people are actually coming in to get screened, to actually be checked out for pulmonary exacerbation here. If there's discrepancies in how often a patient is coming in for a clinical evaluation, we'll notice that we may not be detecting a pulmonary exacerbation. We don't have that data there. So what we're probably finding out is that we're probably finding a lot of false negatives here of people maybe experiencing a pulmonary exacerbation, but they may not be coming in to get it clinically evaluated for it.
Okay, so in other words, your prediction model is predicting that an exacerbation is more likely to occur, but that's not what's happening at this sort of population level.
Right.
Okay, great. Thank you.
Good morning. Great talk. Albert Farrow, CF Foundation. Now, I realize that we're very fortunate in the CF community to have the patient registry. And yet I also know what a powerhouse Cincinnati Children's is, and all sorts of chronic disease states. So I'm really curious if you've done any work, or if your colleagues have done any work in other disease states, maybe such as asthma, looking at these racial biases that may help inform your future work in CF.
Great question. Thank you so much. Yeah, as a postdoc fellow, I actually just started a project on developing an algorithm to predict future asthma admissions within Hamilton County. And so as I've been developing that algorithm, it's in the very, very early stages at this point here. But one of the things that I'm keeping in the back of my mind working on this project here is, how do you actually evaluate a model here like asthma admissions for group bias here between various different races? So that is actually something that I'm starting to work on now, and hopefully that there will be some great outcomes from that. Thank you.
Well, Kathy is walking up. An app question is, what years of registry data were used?
So the years of registry data that we use came from January 3rd, 2003 to December 31st, 2017.
Hi, Kathy Ramos from University of Washington in Seattle. My question is based on what I'm learning from the Google trial that's going on right now, where they get so much data, so their algorithms are just so much better when you type a search into Google. And I'm wondering if the same thing is happening here, that the white patients contributed so much data to the algorithm you tested, and Hispanic ethnicity is about 10%, maybe a little bit higher, and maybe the Black race is just below the threshold where it can influence the algorithm. And you said that you picked different sample sizes to test the algorithm, but have you made an algorithm that had equal sample sizes of Black and Hispanic and white participants?
Yes. So one of the things that I noticed looking at, say, the sample sizes that are shown there was that the cohort that we used was predominantly made up of white patients and those who are non-Hispanic. So to address that, we actually did on the side, and I didn't have time to show it here, was we did a simulation where we just randomly sampled 500 white patients, 500 Black patients, and 500 patients of another race, put them all together so that the way there's no differences in sample sizes between that. And then we simulated this kind of the same thing. We did the ROC curve analysis there, find that overall cutoff probability overall, and then apply it for each racial group. And then we did that simulation, and we still found discrepancies between race. So this is not necessarily a sample size problem. It goes a little bit beyond that. It could be because of how the data is collected. It may be how it's getting in there, or it may just be based on the algorithm. The algorithm doesn't know how to handle that group fairness there. And that's something that we're going to be doing for future work.
Yeah, I think it's confusing to a non-programmer, maybe where the algorithm's coming from here. And so the algorithm that the second one, the sort of side one, was that a new algorithm with the 500 from each?
Uses the same predictions from the precision medicine algorithm. We just built a simulation here to show that even if you have equal sample sizes here built up here, you're still finding discrepancies.
Yeah, it would be interesting to build an algorithm with equal proportions or similar proportions, or just more enriched for these underrepresented groups potentially.
Okay.
Yeah.
Thank you.
One more app question, and I sort of have a dovetail, is so the FEV1s that you're pulling, were those absolute values or percent predicted?
Percent predicted.
So which equations are you using? Because we know that some of the spirometry reference equations because they include race, and some institutions are removing that because race in PFT equations may not actually be predictive. Do you think that involved
Yeah, that is actually one of the things that we're going to be looking at, is looking at FEV1 percent predicted values and how that's actually attributed to race. Maybe that's what's causing some of the discrepancies that we're seeing here.
I can just follow up on that. So we know that if we use race-specific equations, we can actually make Black individuals look healthier than they are. And so if in the algorithm we're telling it that they're healthier, then its ability to predict those exacerbations may be skewed. So you can look at either using race-neutral equations or even just looking at the absolute values and kind of removing any of that race-specific work.
Cool. Thank you for the suggestion.
I didn't plant that question, but.
Any last questions? Thank you so much. That was excellent.
Thank you.
Great. It's my pleasure to introduce our next speaker, Dr. Verki from India, who's going to share some of their experiences in cystic fibrosis in their population. Welcome.
Good morning. Thank you for this opportunity to share some data from India on cystic fibrosis. I am presenting this on behalf of myself and Dr. Grace Paul from Nationwide Children's Hospital, who is my collaborator in CF India project. This one. So I have no relationships to disclose. So CF is a global disease with many patients yet to be diagnosed living in different parts of the world. So from India, CF was first reported in 1968, but for the next 3-4 decades, generations of pediatricians were taught emphatically that CF is a very rare disease and it affects only Caucasians. So as a result, not many cases were diagnosed, but in the last 2 decades, there has been a growing interest in CF, as shown by the increase in publications in the national and international journals. To give a bit of background, in India, we have a population of 1.4 billion, and 24 million babies are born each year. We have drastically brought down the infant mortality rate, but it still stands at 30 per 1,000 live births. With regards to cystic fibrosis, we do not have an accurate data about the incidence, but it is estimated to be 1 in 40,000 to maybe 1 in 100,000. And we do not have data on mortality due to CF or how many babies died due to CF. So the question is CF contributing to the high infant mortality rate in India? Obviously, we do not have information to answer this question, but it is important to understand the profile of young CF patients who die. So the aim of our study is to describe the demographics and phenotypic and genotypic profile of infants and young children less than 2 years who died due to CF complications. Study was done in Christian Medical College, Vellore, which is a tertiary care teaching hospital in the southern state of Tamil Nadu. Incidentally, the center reported the second Indian case series in 1980 of cystic fibrosis. From 2010, we have been systematically following up the cases with cystic fibrosis. And in 2018, we got access to genetic testing, almost free of cost because of funding from Cystic Fibrosis CF Foundation, USA. And since then, we've been able to diagnose and confirm more and more cases. In India, NBS for CF is not done routinely. Hence, the average age of diagnosis is about 4.8 years. Treatment is mostly self-funded. Even in the public hospitals, patients have to pay for some of the treatment. So this was done as a retrospective chart review. Confirmation of diagnosis was done by sweat chloride testing or CFTR sequencing. The period of study was 2012 to 2023. During this period, total of 172 patients were diagnosed. From this map, you can see where these patients come from. We get a lot of patients from the eastern and northeastern parts of India in our institute. So most patients are from Tamil Nadu, where our center is, and West Bengal, and some from the adjacent states and the adjacent country of Bangladesh. About half of them are actively followed up, but we have a lot of patients lost to follow-up, about 26%, and we fear many of them have died. Documented death, about 45 patients, that is 26%. Less than about 22 children have died below the age of 2 years, and majority of them under the age of 1 year. This cohort consisted of 15 boys and 7 girls from 21 families. Mean age of CF diagnosis is 4 months, and mean age of death is 4 months. 82% had died within 3 months of diagnosis without really benefiting from the initiation of the CF-specific treatment. The other point is that these 21 families reported there were 11 additional deaths in the families due to symptoms suggestive of CF. This was never diagnosed nor accounted for. These two maps show where the residences of these patients are. As you can see, the first map is all the patients, all the children, 45 who died, and the second is of infants who died. So mostly these are from closer to our center, and we may not have accurate information from those who died who live away from the center. How did they present? 100% of them had severe failure to thrive. Other predominant symptoms were respiratory, recurrent or severe persistent pneumonia, steatorrhea, diarrhea, a significant electrolyte imbalance of pseudo-Bartter syndrome, significant malnutrition with anemia and edema, and some of them had cholestasis, prolapse of rectum, kwashiorkor type of skin rash, and intracranial or GI bleed. All patients were pancreatic insufficient. We documented very low fecal elastase level in 10 of them. 3 of them had clinically evident fat-soluble vitamin K deficiency. This chart shows the nutritional status, which is the mean weight for age Z-score from birth to diagnosis. As you can see, at birth, the mean Z-score is minus 1.03, and that drops down to minus 4.9 at the diagnosis at mean age of 4 months. But the interesting fact is that when they visited the clinic for vaccination at about 6 to 8 weeks, already they had dropped their weight for age Z-score to minus 3.3. There we missed an opportunity to pick them up. Confirmation of diagnosis and time of death. Sweat test was possible only in 10 because they were very critically ill most of the time, and 3 of this was non-diagnostic values. CFTR sequencing was available for all of them. And in fact, in 15 of them, the diagnosis was confirmed only after death based on genetic testing on the saved sample. This shows the genotype of babies who died. 20 of them for homozygous for pathogenic mutations, 9 for the most common del phenotate, and 4 for homozygous for C1029 del C. Incidentally, in CFTR2 database, there are only 17 patients with this. The other 7 variants, 6 of them are reported in CFTR2 database, and the other 1 of them is not. Respiratory cultures shows predominantly Pseudomonas in these young babies, Staphylococcus, Klebsiella, and Stenotrophomonas. Chest X-ray showed hyperinflation in mostly all of them, and this baby had bilateral pneumothorax at the time of death. Bloodstream infection was common. Organisms included Pseudomonas aeruginosa, Staph aureus, and Burkholderia capacia. Severe pneumonia, bilateral severe pneumonia was the cause of death in the majority. Acute intracranial bleed was present in 1 patient. I would like to discuss a few points in relation to these findings. One is infant mortality due to CF. It is just the tip of the iceberg. Here I have presented from a single center reported deaths of 22 in a short period of 10 to 11 years. Beneath that, the families had reported 11 sibling deaths in the same families. And during the same period of observation in hospital, we lost another 9 babies who have, I'm sure, had clinical CF, but we were not able to diagnose at that time because we did not have the diagnostic facility of genetic testing. In addition, many, many more we may have missed because we didn't suspect CF at that time. This is only one center. There are many centers in my own state as well as all over India which handle similar volumes of infant deaths. So the number of babies who are dying undiagnosed is many more. Second question is CF contributing to infant mortality in India? We did a small retrospective study in our PICU over 3.5 years. There were 81 deaths due to all causes between the age of 1 month and 6 months. 7.4% of them had died of CF, but at that time we did not know they were dying of CF. They were diagnosed as bronchiolitis, septicemia, etc. But with the help of the saved DNA sample, we were able to make that diagnosis later. And this again is likely to be an underestimation. Then what is the true burden of CF in India? So data from North India shows, this is a recent publication which showed the carrier status of CFTR mutation is 4.5%. This is a very high number, which is similar to many of the countries where Caucasian population lives. So we repeated the study on cord bloods in Vellore. Our team collected and analyzed 487 cord bloods from sequential deliveries, consecutive deliveries, and did CFTR, next generation gene sequencing. Carrier's rate of pathogenic or likely pathogenic CFTR mutation was 1 in 41, that is 2.4%. From this, using Hardy-Weinberg formula, we could estimate the incidence as 1 in 6,600, compared to much different numbers which were predicted before. In India, with 1.4 billion people and 24 million infants born each year, this could mean more than 3,000 new infants with CF are born, prior to estimates of 240 to 600 cases per year. Incidence in India is in USA is 1 in 2,500 to 3,500, with about 1,000 new cases per year. You may read about this in the poster 345, and I would like to acknowledge Dr. Sharath Ranganathan, who is present from University of Melbourne, who funded and supported the study. The points we learned through this exercise, we share with other medical professionals in India. We have conducted series of educational sessions, the length and breadth of the country, raising awareness about the condition. So newborn screening for CF, we know, will be ideal for best outcomes. But to prevent infant mortality, are there any alternatives? If you look at this graph from UK, looking at mortality rates due to CF from 1968 to 2000, the top line is the post-neonatal deaths. We can see there is a drastic decline from 1970 to 1980-85. This is the time before newborn screening was started. So this is achieved through better diagnostics and better supportive care. So this is what we have to do immediately in India, that we have to step up the diagnostics and improve the basic care, right now to prevent this mortality. We do train doctors in pattern recognition, because without newborn screening, we have to pick up these patients right then when they present, and this can save lives. As an example, I'm just sharing this screenshot of the computer with the results. This is a little baby, a 3-month-old, who presented to an adult hematology center for evaluation of anemia of 4.7 grams. So all the investigations for anemia was done, bone marrow examination, the works, but the diagnosis was not made. But on the same screen, you can see another result, which shows albumin, very low albumin of 1.7 grams percentage. So this kind of a combination, severe anemia, hypoproteinemia, hypoalbuminemia, and soon the baby develops edema. This triad is almost pathognomonic of cystic fibrosis. So this baby actually died a month later because it was not picked up at that time and later came with a respiratory infection and died. But on the other hand, the next patient is another 3-month-old who presented to the pediatric emergency on a hot summer day with a bit of vomiting and lethargy. And let's look at the arterial blood gas. Sodium 115 millimoles per liter, potassium is very low, and chloride is extremely low, with a pH of 7.62. This typical pseudobarter presentation, the juniors manning the pediatric emergency are trained to pick up this type of picture. And diagnosis was made within 1 day and treatment was started immediately. And we were able to save this baby. In fact, we consider presentation of pseudobarter syndrome as an opportunity to early diagnose patients. Use of another point we teach is using the test fecal elastase to make an indirect diagnosis, because that means there is pancreatic insufficiency and cystic fibrosis is the commonest cause. Our motto is treat first and diagnose later, because if we wait to confirm diagnosis, we will lose that patient. Even if you can't save the baby, save the DNA sample, and confirmation of diagnosis will benefit the family with genetic counseling. Early identification of cases as close to neonatal period using clinical clues is our aim. One of the methods may be, we routinely monitor weight at 6 weeks when they come for vaccination. So if we can pick up those who are falling behind and evaluating, including CF as a differential diagnosis, that may be a way. So this is a single center study, and hence there are limitations to this, and also it's a retrospective data collection. In summary, in unscreened population, there are early childhood deaths due to undiagnosed CF. Challenges include non-specific presentation and difficulty in sweat testing these very critically ill babies. So we need a systematic study to understand the true incidence of CF in India. We need a pilot newborn screening study to make sure, to see if these estimates we made are correct. If we can prove that CF is a significant contributor to infant mortality, I am sure the administration, the government will take it up and do the needful to prevent these deaths. For a screening strategy in India, out-of-the-box ideas may be needed. How we go about screening these patients, because 24 million babies per year have to be screened year after year. So the logistics involved is huge. I would like to acknowledge my colleagues and residents from the Department of Pediatrics, Christian Medical College Vellore, the team of geneticists from Medical Genetics Department and Research Lab, Dr. Aaron, Rekha, and Sumita, CF Care team who works with me at CMC Vellore. Especially my thanks to CF Foundation. With a grant we received in 2008, we were really able to make a lot of difference for CF care in India. And Nationwide Children's Hospital Pulmonary Department and Dr. Grace Paul and all her colleagues who have supported us in many ways through education and support. Thank you.
Thank you for this excellent presentation and very sobering results. It's really important work that you're doing. I'll open this abstract for questions. We got one.
Bill Farrell from Wisconsin. Thanks, Neha. That was really very, very interesting. I want to make a couple of comments and ask you a question. The most striking observation, I think, is the estimated incidence of CF. I assume that others would agree, but an estimated incidence of 1 in 6,600 live births is not that far from the United States. We're about 1 in 5,000 now in the USA. And the number of new cases that would be identified annually is about 4 times what we're identifying in the United States. Second comment, I think your clinical observations on presentations, and the most striking one to me was that case of pneumothorax, give us a historical window into what it was like in the United States prior to the advent of sweat testing or even newborn screening. So that tells you what a extremely severe disease this was, with delayed diagnosis and the treatments we had in those old days. So here's the question I wanted to ask you. You must have cases of CF with pancreatic insufficiency, and you'd expect at least 10, maybe even 20%. So do you have any indication from your genetic data on cord blood or the study in North India that there are variants that would be predicted to be associated with pancreatic insufficiency?
Yeah, so there are variants associated with pancreatic insufficiency as well as sufficiency. In fact, that is one of the problems. There is, I think, compared to the data from US and other European countries, there is a higher proportion of pancreatic sufficient cases. They present with much atypical presentation, and they don't present very early. They get diagnosed much later. As a result, their pulmonary status worsens very rapidly by the time they reach the end of the second decade. So we know the variants which are associated, at least from our data, at least 3 or 4 variants are commonly associated with pancreatic sufficiency, and the rest are with pancreatic insufficiency.
Hi, Katie Singh, genetic counselor at Miller Children's. Was your data from North India from carrier screening?
No, they were volunteers, healthy volunteers.
Because a lot of the big carrier screening labs in the US will collect ethnicity data. And sometimes some of the labs will actually ask South Asian versus East Asian. And I wonder if you could approximate carrier screening on Indians living in the US with a South Asian background to get a carrier rate there that you could help support your cause as a different data set.
Yes.
Maybe the actual number is very small, the Indians living in the US, so we do have some data, but the registry does not divide it, puts all Asians. Sorry, I'm Grace. We know that in the CF-US registry, there's very limited data available on the actual number of patients of Asian ethnicity. It does not divide into Asia, South Asia, it just tells Asia. So I know one of my colleagues, Sriram, has looked into this, and he may give you specifics, but we do not have that. So it's not comparable in one way, is what I'm saying.
But that's the CF registry data, right?
Yes.
I'm talking about individual labs that do carrier screening.
So
Like Invitae, for example, or GeneDx, like the big commercial labs, when you do general population carrier screening, they ask ethnicity, and some of them specify South Asian versus East Asian. So I'm wondering if you might get that sub-data.
okay, we can
I don't know.
try. Yeah.
Hi, Susanna McCauley from Chicago. That was a wonderful presentation, and as Dr. Farrell said, a great reminder of what early CF can do. The prior question and comment set up well for my question. So we have done a lot of work on newborn screening, and we've used the CF Foundation registry to look at variants that are in the registry versus what newborn screening panels in various states might pick up. Megan McGarry led that. But as Dr. Paul pointed out, we, in the United States registry, we use census definitions, and we have this category of Asian. And many of my friends who are from India or whose families are from India, they don't recognize themselves in that category. Asia it's a very, very large, diverse population. So I'm just wondering how those of us working on equity issues can learn from you and how we can collaborate, because we certainly have had missed false negative newborn screening in families from South India and from Pakistan. We don't have the ability really with these big data sets to look at where people are from, where there's no self-reporting. So I'm just wondering what your thoughts are about trying to learn together to make this robust for cross-continental equity.
Yeah. So within India, we have noted a lot of regional variation in the variants between South and East, because that's where our patients are coming from. So I think if we get more data, we may even be able to say something from a postcode. You give the postcode, we'll tell you the genetics. It's almost as remarkable as that, the difference. So we should be able to work together with, to do more studies in different parts of India to understand what variants are prevalent in where, and that will help the understanding of CF newborn screening and recognition of cases in US as well.
Yeah, and I recognize it's so colonialist to say, like, how can you help me? I really admire what you do and how you're collaborating, and I just want to give my greatest appreciation to you.
We just have one question from online. Can you comment on aquagenic wrinkling and of the palms as a screening tool?
Yeah, so aquagenic wrinkling.
Oh, sorry. Can you comment on aquagenic wrinkling of the palms as a screening tool?
Yeah. So aquagenic wrinkling is just immersing hands underwater, and it wrinkles quickly in CF patients. I think Grace Paul has done a study on young infants. You may want to share that.
So we did this study at Nationwide Children's, but the bottom line is when we immerse our hands in water, it wrinkles up. But in kids with CF, the hands wrinkle within 3 minutes compared to a healthy person, which takes 15 minutes. So this is a very crude test to do. All you need is a bucket of water. And how we did it at Nationwide with my team is we had a healthy cohort, so basically normal newborn screen, and then we picked our CF kids, everybody less than 2 years of age, so from 2 weeks to 2 years of age, and we made some ways and how we would keep their hands in water, and then we checked their palms for wrinkling every 30 seconds to 1 minute, and we were able to show that clearly there was a difference in the time to wrinkle. That was our outcome. And then once we had this, we also correlated with what was their IRT and what was their genetics, what was their sweat test results. And there was a clear correlation. So the higher the IRT, lower the time to wrinkle. So it was like a negative correlation there. And so our thought is this can be a very crude test that is applicable anywhere in the world. All you need is a bucket of water. So once another slide here would have been, we looked at aquagenic wrinkling plus failure to thrive. In that case, our positive predictive value for CF was much higher. We were able to even pick up 20% of CF cases. So again, this is very small cohort, but there's so much of applicability and practicality in doing something as a very crude clinical screening tool. So I think these are the things we're talking to doctors from other low and middle income countries where we can make a difference. And the thing is, if we miss, that's fine. But if we pick up somebody, even if we pick up 70% of patients, it makes a huge difference because the numbers are huge. So yeah, that was my thing on aquagenic wrinkling.
I'm not sure there's time for this. But Sneha, you mentioned pilot project of newborn screening. I think it's worthwhile for you to describe the planning that's gone into this. What's been most impressive to me is that your center, your state, has greater capability for CFTR analyses by sequencing than the majority of the states in this country. And that's why I think you'll be able to proceed with newborn screening.
That'll be wonderful. So we've been talking with Dr. Farrell himself about a protocol using IRT and maybe PAP, which is pancreatitis-associated protein, as the two tests to be done to improve the specificity. Checking DNA will be much more difficult because it's very diverse. There are very many variants, and we may not be able to select a panel of variants for this screening. So we have been in conversation, planning this newborn screening.
Thank you so much for a great presentation.
And then last, we will welcome up Emra Gassili to talk about environmental exposures and spatiotemporal effects that characterize rapid lung function decline in a Midwest U.S. cystic fibrosis cohort.
Can I touch you? I need to go out. Okay. The arrows at the bottom. This one? Or the bottom of the screen. Which one? All the way at the bottom. You see all of it? Okay, how about this? Okay, it's not right. Later ones. Yeah. Okay. All right, thank you. Thank you, everyone, for being here today. And thank you for organizing this session. And my talk is, let me briefly mention about myself first, right? And my name is Emrah Gassili, and I'm from Cincinnati Children's Hospital Medical Center. And today I'm going to be presenting a part of our work with some other people from Cincinnati Children's Hospital. And my talk is going to be on environmental exposures and spatiotemporal effects that characterize rapid lung function decline in a Midwest US CF cohort. And here is my disclosure slide. And this work partly, supported by this NIH grant and this CFF fellowship. And here is a brief outline of the talk for today. And I'll start by providing definition of rapid lung function decline, which is what we use for predicting rapid disease progression in CF. Rapid lung function decline is defined as prolonged drop in lung function relative to the center and or patient-specific norms. And the lung function was measured with FEV1% predicted in our work. And this kind of declines can occur throughout the lifespan of individuals with CF because of many different reasons. And here on the right, I have a figure which is kind of showing a lung function trajectory of subject from our study cohort. And this is, it's not strong, okay. This is for a female CF subject, and on y-axis we have her lung function, which is in FEV1% predicted, and it is plotted against her age, which is in years. And as we see, like she's kind of having not very but stable lung function at the very beginning until somewhere around age of 16. And then we see a kind of rapid decline after age of 16. This is kind of a visual example for the rapid decline in CF that we want to predict in our work. And environmental exposures and community characteristics, which we defined as geomarkers, explain nearly 50% of the variation in CF lung function. Although it is critical to intervene prior to irreversible lung damage, there is limited information on predictive geomarkers for this purpose. And again, our goal is to localize social and environmental determinants of rapid lung function decline in CF. And our study is based on the data that is collected at Cincinnati CF Center data. Actually, what I am using is kind of a subset of these data collected at Cincinnati CF Center data. I had to use the subset of it because of the missingness in some of the variables that we used as predictor in our final model. And simply in this cohort, we had 152 CF subjects who received care at Cincinnati CF Center between 2012 and 2017. And we also removed observations after lung transplant. And this table is kind of providing the characteristics of the clinical and demographic variables for these 152 subjects. I'm not going to go into details of these, but almost half of the subjects were male, and almost 56% of them were F5 or 8del homozygous mutation. And the median duration of follow-up was 4 years, which has ranged from 0 to 7 years. And median number of observation per subject was 19, which also has ranged from 1 to 87. And in a recent published paper in Pediatric Pulmonology, and we have shown that some geomarkers associated with rate of FEV1 decline, and these geomarkers included percent green space that was defined as the percent of 30 meters by 30 meters pixels within 400 meters of the residential address classified as green by the National Land Cover Database. And another geomarker was elemental carbon attributable to traffic sources, which is known as ECAT and traffic-related air pollution marker. And another one was Community Deprivation Index, which assesses extent of poverty, vacant housing, assisted income living, educational level, median income, and health insurance coverage for a given neighborhood. And here I simply created maps for these 3 different geomarkers around Cincinnati CF Center. The first one is for the ECAT, and the second one is the deprivation index, and the last one is percentage green space. And this green color is expected to be associated with better lung function. And this small table is kind of providing the summary statistics, like median and range for each of these geomarkers. And compared to the national averages, we observe that we are having higher averages for all these 3 geomarkers for the Cincinnati CF Center data. And here I have a spaghetti plot for the data that we are using in this work. Again, on y-axis I have lung function, which is FEV1% predicted. That was plotted against age in years on x-axis. And the gray dots are standing for the FEV1 values that was observed for different subjects at different time points. And we randomly selected 3 subjects and highlighted their lung function trajectory over time. And as you see from these highlighted trajectories, we are able to observe within and between patient variability over the time in lung function. And there is definitely heterogeneity and non-linear trend. And an unstationary Gaussian linear mixed effects model for longitudinal FEV1 was used by Cystic et al. And that's kind of a model that we have been extensively working in our lab during the last several years. And this is kind of, capable of accounting for all these things that I listed above. And this model is having this form, and I'm not going in details of the model for now, but I'll give some details later today. So what is needed, what we need is a prediction tool that incorporates spatial correlation and induces simultaneous variable selection. And incorporating spatial correlation. And here I focus on the model, that Dr. Cystic has introduced for predicting rapid lung function decline in CF. And the model can be written in this form where Yij is nothing but it is the response variable for subject I at time Tij. And mu I of Tij is mean response. And we have Ui, which is a random slope term that represents time constant differences among subjects. And this Wi of Tij is a stochastic process. Here specifically we used integrated Brownian motion, which is representing change in a subject's FEV1 over time. And what I did was adding this Si of Sij, which is written in red, and which is another term that we want to use for representing change in patients' FEV1 based on location. And this Zij is nothing but it is a measurement error. And here for this Si of Sij, we specifically assume exponential correlation structure. So this correlation is kind of assumed to be decaying as the distance between observations increases, as we see on the figure on the right. And the second thing that I tried to do modification on the model was obtaining simultaneous variable selection. And if you want to get like simultaneous variable selection in a regression model, there is some different ways, but we wanted to implement a penalized regression model, which is, inducing simultaneous variable selection, and at the same time, it helps for predicting the outcome of interest. We specifically use a spike and slip shrinkage prior. I call it prior because we implemented our model in a Bayesian framework. So by using an appropriate shrinkage prior, one can obtain a penalized regression model that will produce or induce variable selection when you fit the model. And spike and slip prior is one of the modern shrinkage prior that has some advantages compared to other traditional priors. And this is kind of a mixture distribution on a regression coefficient with density function that are peaked at 0. And that spike is for the coefficient of the predictors that has 0 effect on the outcome, and also have large probability mass for a wide range of non-zero values, which is the slab part of this mixture distribution that we use for variable selection. And using this kind of modeling induces adaptive shrinkage on coefficients, and it enables Bayesian false discovery rate controlling method to select important predictors. This Bayesian false discovery rate is kind of the false discovery rate in frequentist statistics. So, this is kind of important to control it below some level, especially if you are having large number of variables. Like this may be, you may have some examples from like omics type data, where you have like thousands of like proteomics biomarker or genomic biomarker, and you want to do variable selection. You definitely want to control your false discovery rate below some level to avoid large number of false discoveries that may cost a lot of time and money. So using this kind of penalized regression model also helps avoiding overfitting and simplifies models. It improves interpretability, and it can lead to better predictions. And I have done some simulation, but I'm not able to present it. First, we did some simulation, and we were able to confirm that our method was efficient to induce variable selection, especially when the correlation between the predictors were not that high, when it was less than 0.8. And we implemented, now I'll be presenting some results from our application on the Cincinnati CF data application. And we implemented the proposed model for the Cincinnati CF Center data. And first, I included this list of covariates in our model, which is including some of the commonly used clinical and demographic variables, plus 3 different geomarkers that I mentioned earlier, and their interaction with encounter age. Even with a small number of predictors, the model is having this form. So imagine when you have larger number of predictors, you will need that variable selection to get a simpler model. And we compared our spatial model, which now I denote with SSS-LME, which is spatial spike and slab linear mixed effects model, with 2 other Bayesian and multiple frequentist LME models with different spatial correlation structure. And we evaluated model fits and prediction accuracies by using differences in AKK information criterion and Bayesian information criterion and root mean square error. When we fit our model, we also provided Bayesian false discovery rate with coefficient estimates and model output. And I have a table here which is kind of summarizing our findings, the results of our applications. In the first column, I have some details about different models that we applied for this data. The second column is giving some idea about the spatial correlation structure that was implemented. And third column is giving information about delta AIC, which was computed as AIC of the first model minus AIC of the following corresponding model that we want to compare with the null model. And then DBIC is also computed in a similar way. So higher DAIC and DBIC are better, and the smaller RMSE is better because it is quantifying the amount of error in prediction. The first model is LME model, which is traditional random intercept LME model, which is traditionally people use for predicting rapid lung function decline in CF, which is simply ignoring the spatial correlation. So I consider this kind of base model and then implemented other models on this, top of this base model. For example, second row is for the same LME model plus an exponential spatial correlation term. And we see that there is, positive values of DAIC, DBIC. So that means kind of improvement compared to the LME model in the first row in terms of model fit. But yeah, and I'll skip, details of some of the other models, but similarly, we consider different types of traditional random intercept LME model plus some different types of spatial variability, as we consider Gaussian and some other. I'll move to this purple row, which is the case we use stochastic, frequentist stochastic LME model. That's kind of what we used in our recent publication, which is ignoring the spatial correlation, but still we see some improvement in model fit and slightly improvement compared to the base model in terms of RMSE. And then we implemented 3 different Bayesian models. And the final model, which is spatial spike and slab LME model, which is assuming exponential covariance structure for the spatial variability, is having the best improvement compared to the other models because it has the highest DAIC and DBIC, and it also has some improvement in the model, in the prediction power, because it is returning the smallest RMSE value among the models that we have studied. And I can say, this SS-LME has the best prediction accuracy, and it has the best model fit. And that was followed by the spatial Bayesian elastic net model. That was another Bayesian model that we implemented by using different types of shrinkage prior. And as I said, using this kind of penalized regression model is allowing you to obtain a Bayesian false discovery rate for each of predictor in your model. So by using this Bayesian false discovery rate, you can do variable selection. Here for this model, I have this figure which is showing the estimated Bayesian false discovery rate for each of the term in the model. And when we want to control this Bayesian false discovery rate below 0.01, we are selecting these predictors with green bars. And some of these are having green bars, but we are not able to see because of their very small Bayesian false discovery rate. But we were able to select all the predictors in this example when we control this Bayesian false discovery rate below 0.05. But for these kind of examples, if you are handling with a large number of predictors, it is better to go conservative with this choice of threshold we are using. Imagine you have a proteomic data and you want to identify predictive biomarkers for the rapid lung function decline. And let's say you have 1,000 predictor, and when you control this Bayesian false discovery rate at below 0.05, you are simply allowing, around 50 false discovery, and which may be, problematic in this later step when you want to distinguish these false discoveries among a large number of discoveries. So it is better to, like have something that will be controlling this kind of pulse discovery rate below some small threshold. And this slide is giving the association between clinical and demographic variables and lung function. The first figure is showing the posterior mean estimate and 95% credible interval for the coefficient of each of these main effect terms in our model. And second figure is showing the same thing for the interaction term. So these values are kind of giving idea about, information about rate of decline in epi1% predicted. So briefly, I can say that what we observed from here, an increase of 0.1 mg per m cube of ECAT was associated with 0.125% predicted per year more rapid decline, and an increase of 0.1 unit in deprivation index was similarly associated to additional decline of almost 0.1% predicted per year. As a conclusion, we didn't do too much application on this so far. I used, Cincinnati CF Center data, but I can say that our findings suggest that incorporating spatio-temporal effects and geomarkers in our novel Bayesian stochastic LME model, which was based on spike and slab, resulted in an improved prediction tool for predicting rapid CF disease progression. And if future work, it will be interesting to implement this model by using the CFFPR data with a larger set of geomarkers. Also, it will be interesting to, implement these for the Cincinnati CF Center data with, again, larger set of predictors. And another future work will be implementation of these, implementation of risk monitoring at point of care. And I would like to thank the NACFC organizers and CF Foundation, and also the Cincinnati Children's Hospital Medical Center. And here is the list of co-authors. And thank you. Yeah.
Thank you. Anyone have any questions? Please feel free to come to the mic or place it in the app.
All right, start us off. So you have green space deprivation and air pollution, and these measures from your original maps look quite correlated in that they were providing similar information. And I wonder if your model deals with the collinearity of the variables that you've included.
Yeah, that's a good question. I think when you use lasso type models, that induce simultaneous variable selection, that's kind of eliminating the variables that are highly correlated to each other. So using this spike and slab type regression model takes care of these. And yeah, if there, if there is set of predictors that are highly correlated, it is kind of, only keeping one of them and trying to kick the others out of the model.
Hi, Bob Sun from Boston Children's Hospital. Thank you for this really interesting talk. I had two questions that I think are maybe just two different aspects. One is on your spatial term. I noticed it seems that you have ZCTA or zip code. Is that correct? Rather than point address. Do you worry about in relation to some of your exposure variables, such as the traffic-related air pollution, that things like NO diminish quite quickly with distance, that you worry about misclassification by not having point address?
Yeah, that's a good question. As I said, this is kind of the initial application, and there is it still requires some adjustment for different cases, as you say. I have planned to apply this to a geomarker data that is collected based on zikta level. And yeah, it still requires, more investigation, and probably, I have to do more application to see, how the model performance is changing for different scenarios.
Thank you. And then my second question is sort of I guess a philosophical question about variable selection. And if from an epidemiologic standpoint, we are, on the other hand, interested in a particular exposure based on what we think might be a causal framework. Notice, for instance, that race is not in the one of your covariates, or that we wanted to include things that potentially would be collinear. Thoughts about balancing that versus a statistical approach to variable selection in this case. Thank you.
Okay, I think in this like in Bayesian framework, like when you do assign the prior distribution for coefficient of the predictors, you are able to separate the coefficients that you want to induce shrinkage, or the ones like you don't want to. I'm sorry, let's say it again. Like you can separate the coefficient of predictors, like you want to induce shrinkage and you don't want to induce shrinkage. For example, in this model, I have like encounter age as a predictor, and we don't want to shrink its coefficient. And in another application, I was, like keeping some of the predictors kind of like intrinsic predictors, like mutation, like genotype and gender. And I was avoiding, like trying to kick them out of the model. That's why, like you have ability to control the list of predictors that you want to like perform shrinkage or not. So, yeah.
Hi, I'm Liz Baker. That was actually going to be one of my questions. So very good question. So I was just kind of curious, since you showed all of the different ways that you fit the model, how did that substantively change the coefficients? Right, because you had all those predictors in there. So what happens to like green space when you measure it all of those different ways? Or if green space even ends up in them?
Yeah, that's a nice question. Yeah, it would be, I think, better if I had a like kind of forest plot and show the coefficient estimates with different color from different models. Yeah.
I was just curious.
Yeah, thank you. But I think I just remember, the coefficient estimates from the frequentist model, frequentist stochastic LME model, this purple model. That's what we use in our recent published paper. And we were able to see that these coefficients were slightly increasing compared to what we get when we use that frequentist model that is ignoring spatial correlation. And it is, like inducing shrinkage on the coefficient of all the predictors. If the predictor is important or predictive, then we are not applying too much shrinkage on their coefficient. And if the predictor has like zero effect on the outcome, then the model is shrinking their coefficient somewhere near zero. So you will definitely expect some change on these coefficient estimates when you use this type of model because of the shrinkage that you are performing. Yeah.
Any other questions? Thank you so much for our excellent talk.